Your doctor looked at your blood test. Your HDL cholesterol was high, maybe 1.8, maybe 2.0, maybe even higher. And they told you that your good cholesterol was excellent. Perhaps they told you it was protective. Perhaps they used it to partially offset your LDL in their risk calculation. And you left that appointment feeling reassured about your heart health, at least in part because of that number. I want to tell you something that most cardiologists now know, but that has not yet filtered through into routine clinical practice. A high HDL number does not necessarily mean you are protected. For a significant proportion of people, it tells you almost nothing about whether reverse cholesterol transport, the protective process HDL is supposed to perform, is actually working. The HDL hypothesis, the idea that high HDL cholesterol is directly cardioprotective and that raising HDL reduces cardiovascular events, has largely collapsed in the past 15 years of clinical trial evidence. Multiple drugs specifically designed to raise HDL levels dramatically, including torcetrapib, dalcetrapib, and niacin, failed to reduce cardiovascular events despite producing large increases in HDL cholesterol. One of them, torcetrapib, actually increased mortality. What these failures revealed is that HDL cholesterol measured on a standard blood test reflects the amount of cholesterol inside HDL particles, not whether those particles are doing their job. A high HDL number can mask HDL particles that are dysfunctional, inflammatory, and failing to perform reverse cholesterol transport. In this video, I am going to give you the complete picture of what HDL actually does, why the HDL number on your standard test is an incomplete measure of that function, what HDL dysfunction looks like and who is most at risk, the conditions that produce paradoxically high HDL with elevated cardiovascular risk, and the evidence-based actions that improve HDL function, not just HDL cholesterol. By the end of this video, you will understand your HDL in a way that the number alone can never convey. Drugs that raised HDL and failed to reduce cardiovascular events, 3 major trials. Torcetrapib, dalcetrapib, and niacin all raised HDL significantly. None reduced cardiovascular events. NEJM, Lancet, 2020-2025. What HDL actually does. The reverse cholesterol transport system. High-density lipoprotein, HDL, is produced in the liver and intestine as a small, protein-rich, lipid-poor particle called nascent or pre-beta HDL. Its primary biological function is reverse cholesterol transport, the process of collecting excess cholesterol from peripheral tissues, including from foam cells within atherosclerotic plaques in arterial walls, and returning it to the liver for processing, recycling, or excretion through bile. This is the process that earns HDL the label of good cholesterol. If reverse cholesterol transport is working effectively, HDL is actively reducing the cholesterol burden in arterial plaques, literally removing the substrate for atherosclerosis. This is the protective mechanism that decades of epidemiological association between high HDL and lower cardiovascular risk was originally attributed to. The process. The process works as follows. Nascent HDL particles interact with the ABCA1 transporter on the surface of cells, including macrophages within arterial walls, and acquire cholesterol and phospholipids. As they acquire cholesterol, they become increasingly lipid-rich, transitioning from HDL3 to the larger, more cholesterol-rich HDL2 particles. The enzyme LCAT, lecithin cholesterol acyl transferase, esterifies the cholesterol, stabilizing it within the HDL core. Mature HDL then delivers cholesterol to the liver via the SRB1 receptor, where it is taken up and processed. The efficiency of this entire pathway, not the amount of cholesterol sitting inside HDL particles measured by a standard blood test, is what determines how cardioprotective HDL actually is. HDL function versus level. The critical distinction is between HDL cholesterol, the number on your test, and HDL function, the capacity of your HDL particles to perform reverse cholesterol transport effectively. Standard blood tests measure how much cholesterol is inside HDL particles. They tell you nothing about whether those particles are performing reverse cholesterol transport efficiently, whether LCAT activity is adequate, whether SRB1 uptake is functioning correctly, or whether the HDL is anti-inflammatory or, as in HDL dysfunction, paradoxically pro-inflammatory. 2 people with an identical HDL cholesterol of 1.8 millimoles per liter can have completely different HDL functional capacity. HDL dysfunction. HDL dysfunction is a state in which HDL particles lose their anti-inflammatory, antioxidant, and reverse cholesterol transport properties and become pro-inflammatory and atherogenic. Dysfunctional HDL has been demonstrated to actively promote LDL oxidation and endothelial dysfunction, the opposite of its intended biological role. HDL dysfunction is associated with the presence of inflammatory conditions, including rheumatoid arthritis, lupus, kidney disease, and, critically, metabolic syndrome. The same conditions that damage the cardiovascular system also corrupt the primary system designed to protect it. Metabolic syndrome. People with metabolic syndrome, the cluster of abdominal obesity, insulin resistance, elevated triglycerides, low HDL, and high blood pressure, frequently have HDL dysfunction despite whatever HDL number appears on their test. The HDL particles in metabolic syndrome are small, dense, and depleted of their key functional proteins, including paraoxenase 1, apolipoprotein A-fer, and sphingosine 1-phosphate, that mediate its protective effects. The paradox: in metabolic syndrome, low HDL cholesterol is a risk marker, but raising HDL cholesterol pharmacologically without addressing the underlying metabolic dysfunction does not restore function. Very high HDL. Perhaps the most clinically surprising finding in HDL research of the past decade is that very high HDL cholesterol, above approximately 3.0 to 3.5 millimoles per liter, is paradoxically associated with increased cardiovascular risk in some populations. Studies, including a 2018 analysis published in the European Heart Journal, demonstrated a U-shaped relationship between HDL cholesterol and cardiovascular events, with elevated risk at both very low and very high HDL levels. Very high HDL may reflect impaired cholesterol clearance. The particles are full of cholesterol because the liver is not removing them efficiently, rather than enhanced reverse cholesterol transport. This finding completely undermines the simple higher HDL is better narrative. Inflammatory conditions. Chronic inflammatory states, rheumatoid arthritis, systemic lupus, psoriasis, and chronic kidney disease consistently produce HDL dysfunction, even when HDL cholesterol appears adequate. In these conditions, the acute phase response displaces apolipoprotein A1 from HDL and enriches it with serum amyloid A, transforming anti-inflammatory HDL into pro-inflammatory HDL that actively promotes atherosclerosis. This is one of the mechanisms through which chronic inflammatory conditions dramatically elevate cardiovascular risk beyond what standard lipid panels suggest. Exercise. Number 1. Regular aerobic exercise is the single most effective intervention for improving both HDL cholesterol and HDL functional capacity. Exercise raises HDL cholesterol by 3 to 9%, the most reliable non-pharmacological HDL-raising intervention known. But beyond the quantity effect, exercise specifically increases the proportion of large, buoyant HDL2 particles, the most functionally active subclass, and increases the activity of LCAT and paraoxenase 1, two key enzymes of reverse cholesterol transport. 250 minutes of moderate aerobic exercise per week produces the greatest HDL functional benefit. Resistance training adds incremental improvement to the aerobic effect. Alcohol, the nuance. The HDL-raising effect of moderate alcohol consumption, approximately 5 to 15% increase in HDL cholesterol with 1 to 2 standard drinks daily, is one of the most widely cited arguments for the cardiovascular benefit of light drinking. This effect is real. However, given the emerging evidence from Mendelian randomization studies that the overall cardiovascular benefit of moderate alcohol is less than previously thought, and given that alcohol has significant adverse effects on triglycerides, blood pressure, liver health, and cancer risk, alcohol consumption is not a recommended strategy for HDL improvement. The HDL effect does not compensate for the other harms. Address metabolic syndrome. The most important intervention for HDL dysfunction is not raising HDL cholesterol, but correcting the metabolic environment that creates dysfunctional HDL. Losing visceral fat, reducing refined carbohydrates and fructose, reducing systemic inflammation, and improving insulin sensitivity, the actions covered across this series all restore HDL particle quality and functional capacity more effectively than any drug that simply raises HDL cholesterol. This is the clinical lesson from the failed HDL-raising drug trials. You cannot buy your way to functional HDL with a medication that ignores the metabolic dysfunction driving its impairment. Niacin, vitamin B3 at pharmacological doses, produces large increases in HDL cholesterol, 15 to 35%, and was widely used for this purpose for decades. The AIM-HIGH and HPS-2 THRIVE trials, the largest randomized trials of niacin in people already on statin therapy, found no reduction in cardiovascular events and significant adverse effects, including hepatotoxicity, glucose dysregulation, and an HPS-2 THRIVE increased stroke risk. Niacin for HDL raising is no longer recommended in standard cardiovascular guidelines. Its inclusion here is to specifically address viewers who may have been prescribed or may be considering it. Action 1. Exercise 250 minutes per week, including high-intensity intervals. Aerobic exercise at 250 minutes per week, adding 2 to 3 high-intensity interval sessions, produces the greatest improvement in HDL2 particle proportion and LCAT activity. The high-intensity component specifically increases the enzyme activity that drives reverse cholesterol transport, over and above the effect of moderate exercise alone. If you are currently sedentary, 150 minutes is your starting target. But if HDL function is a specific concern, progressively increase toward 250 minutes. Action 2. Lose visceral fat, the primary cause of HDL dysfunction. Visceral adiposity drives the metabolic dyslipidemia pattern, high triglycerides, low small dense HDL, that characterizes HDL dysfunction. Losing 5 to 10% of body weight, particularly from the abdomen, restores HDL particle size and composition toward the large, buoyant HDL2 phenotype. Waist circumference reduction is a better proxy for HDL functional improvement than total weight loss. A 10-centimeter reduction in waist circumference produces measurably better HDL particle quality in people with metabolic syndrome. Action 3. Eliminate refined carbohydrates and trans fats. Refined carbohydrates, particularly fructose, raise triglycerides, which drives the remodeling of HDL towards smaller, denser, more dysfunctional particles through cholesterol ester transfer protein activity. Trans fatty acids, found in industrially produced partially hydrogenated oils, simultaneously lower HDL cholesterol and reduce HDL functional capacity. Eliminating trans fats from the diet is one of the fastest ways to improve both the quantity and quality of HDL. Most developed countries have now banned industrial trans fats, but they persist in some imported products and in naturally occurring small amounts in ruminant animal fat at levels that do not appear harmful. Action 4. Increase polyphenol intake, particularly from olive oil. The polyphenols in extra virgin olive oil, particularly oleocanthal and oleuropein, directly increase HDL functionality by enriching HDL with paraoxidase 1, the antioxidant enzyme that protects HDL from oxidative modification and maintains its reverse cholesterol transport capacity. The PREDIMED trial demonstrated that the Mediterranean diet, supplemented with extra virgin olive oil, produced greater improvements in HDL functionality, measured by reverse cholesterol transport capacity, than the high-nut Mediterranean diet, despite both producing similar HDL cholesterol levels. This is direct evidence that olive oil polyphenols improve HDL function independently of quantity. Action 5. Reduce systemic inflammation. Chronic low-grade inflammation, driven by visceral fat, gut dysbiosis, sleep deprivation, and chronic stress, directly converts anti-inflammatory HDL into pro-inflammatory dysfunctional HDL through the acute phase response mechanism. Reducing systemic inflammation through the 10 actions covered in the inflammation video produces measurable improvements in HDL functionality, not just HDL cholesterol levels. Measuring hsCRP alongside HDL cholesterol provides a more complete picture of whether HDL is likely to be functional or dysfunctional in any given individual. Action 6. Ask for HDL particle size testing if you have metabolic syndrome. If you have metabolic syndrome or any combination of elevated triglycerides, abdominal obesity, insulin resistance, or elevated inflammatory markers, ask your doctor for HDL particle size testing or HDL subspecies analysis. Large HDL2 particles are the most functionally active. A low HDL2 to HDL3 ratio indicates poor HDL function regardless of the total HDL cholesterol number. This test is available through specialist lipid clinics and increasingly through direct-to-consumer laboratory services. It is the HDL equivalent of asking for ApoB instead of LDL. It tells you what is actually happening, not just what the headline number says. The most important thing I want you to take from this video is simple. A high HDL number is not a green light. It is a starting point for a more complete conversation. The question is not how much cholesterol is inside your HDL particles. It is whether those particles are performing the function that earns them the label of good cholesterol. If you have metabolic syndrome, chronic inflammation, very high HDL above 3.0, or any of the conditions I described, your HDL may not be protecting you in the way you have been led to believe. Share this video with someone who has been reassured by a high HDL number without any further explanation of what that number actually means. Subscribe so you do not miss the next video, where I will go even deeper into the cholesterol picture with the one genetic risk factor that affects 1 in 5 people, doubles their cardiovascular risk, and that almost nobody has ever been tested for. Lipoprotein a. It is coming next.